Hello, everyone, and welcome to the National Dialogues on Behavioral Health Conference Session 2, New Models of Crisis Services Incorporating the National 988 Helpline. My name is Jessica Flick, and I'd like to introduce your host for today, Vijay Ganju. He's the president of the National Dialogues on Behavioral Health. Vijay.
Thank you, Jessica. And once again, at least for some of you, welcome to the second session of our 2021 National Dialogues on Behavioral Health Conference. I am, as Jessica said, Vijay Ganju, and I'm the current president of the National Dialogues on Behavioral Health. And as on behalf of the executive committee, it's my great pleasure to welcome you, and for many of you to welcome you back to the conference. As Jessica has mentioned, that this session is part of a conference which is titled Behavioral Health in the 21st Century, Fast Forward After the Pandemic. I have a friend who I was just describing the conference to, and he said, well, please don't tell them any COVID jokes. And I said, why not? And they said, well, it might take them a couple of weeks to get it. Anyway, I hope some of you got that. The pandemic, unfortunately, is still with us, not what we expected. So in some ways, the thought was to rename the conference. What we're really trying to do is gear up what to do next. So we were thinking maybe we should have called it Fast Forward After the National Dialogues Conference. The theme of the conference as a whole is actually quite simple. As we discussed this in the executive committee, a lot of good things were going on prior to COVID hitting us all. And we thought, well, we've got to make sure we don't lose all the good things we were doing. And then because of COVID, we learned to do a lot of things very innovatively and quickly. And so we felt like, well, what is the future going to look like given both these strands? And so really the conference is trying to bring the sort of strands of all the positive things we were doing in the past with all the learnings of COVID to essentially push us into the future. So the way we're going to do this, I'm going to talk a little bit, as I did in the last session, about National Dialogues on Behavioral Health. And then I'm going to turn it over to Megan Haupt, who's the Chief of Staff at the National Association of State Mental Health Program Directors, who will be moderating the session. As moderator, Megan's going to be introducing all the speakers, and she's also going to be managing the flow from one to the other, and also the Q&As that all of you are invited to ask as we go forward. If you don't have a question but have a comment, please feel free to make it. And as I'll tell you in a moment, the Q&A box at the bottom is the best way to do that. So Jessica, let's go through my slides on a fast track. I think we can go to the next slide. And so I just want to repeat some information about the National Dialogues on Behavioral Health. It is the oldest behavioral health conference, the ongoing conference on behavioral health in the United States. And this is our 62nd annual conference. Usually we have the conference in New Orleans in person, and it's an intimate sort of conference where about between 100 and 200 people gather. And the emphasis of the conference is on discussion and dialogue. And it's a great opportunity for networking. And, a lot of people have described this conference as a jewel of a conference, not just because of the content, but as you can see in the picture, that's some of the executive committee and some of the attendees having funds on the street just outside the hotel where we have a conference. I think this particular picture was sort of coinciding with Halloween in New Orleans. The last thing I want to say about organization is it's 100% voluntary. Nobody on the executive committee gets paid. And so all this effort is really done because of the dedication and the sort of work that the executive committee puts into the conference and the other activities of the organization. Next slide, please, Jessica. And so, you know, I'm not going to read all these, but it gives you a sense. Each year we have a different topic, so that draws different audiences. But, you know, as you can see in the last 4 or 5 years, we've had sort of topics related to the criminalization of persons with mental illness, the notions of recovery and resilience and how that affects the design of our behavioral health systems, how we create value, how we measure value. And last year we had a very vigorous discussion and dialogue on implementing behavioral health crisis response at state and local levels. And this session really is sort of like the sequel of that whole conference agenda. Next slide, please. And, you know, when we have the in-person conference, we also have a pre-conference, and that is usually on the Sunday before the conference starts. But again, we cover a lot of the cutting-edge topics that the field is in the process of grappling with, including school mental health, artificial intelligence, you know, again, the issue of mindfulness, alternative medicine, and how that interfaces with the work we are all doing. And these are very, this is a whole day conference on these topics, and we really have experts from presenting from different angles on these topics. Next slide, please. And just, you know, we have the list of all the people who are members of the executive committee, and you know, unfortunately, they can't all stand up right now, but all of them have been very committed and active in sort of making this particular conference happen. Next slide, please. And we have several conference partners, including the National Association of County Behavioral Health and Developmental Disability Directors, NACBID and WICHE, the Western Interstate Commission of Higher Education, and the National Association of Mental Health Program Directors, and these different organizations are also represented on our executive committee. Next slide, please. And again, we have sponsors for the conference, and this year, this is the list of our 2021 conference sponsors, my bad. And that's Access Health Louisiana, Benchmark Human Services, and Genoa Healthcare. Excuse me. Next slide, please. And so, as I said before, just a few housekeeping instructions. Please use the Q&A function to ask questions or make comments. When you do that, please include your name and the state. As we discuss this, I think Jessica is going to ask the askers of questions if they would like to read their question, and that is an option that you will also have. CEUs are available, and I'll talk a little bit more about that. Closed captioning is available, and if you want that, you need to turn on the subtitle function that's at the bottom of your screen. And then please, please, please complete the online evaluation. There is the URL for it is in the letter that you all should have received, but also at the end of the presentation or of this entire session, there will be a screen that comes on with the URL, and if you click on it, it will take you directly to the evaluation for this session. Next slide, please. Jessica, oh yeah. And if you want CEUs, then please send an email if you haven't done so already to Melanie Norwood at the email address that's there. And then at the end of this session, what we will be doing is providing a unique code word at the end of the seminar, of the webinar, and that's the code word that you need to submit on the CEU evaluation form that you should have received from Melanie Norwood. Just to be clear, the CEU evaluation is different than the evaluation that is going to show up on the screen at the end of the session. Next slide, please. And so that is the URL for it. It should appear, but if you you should have it in your letter, but if you note it, it's sort of something that you can just enter in your computer and it'll take you straight to that. So thank you again for participating and being part of this session. And with that, I'm going to turn it over to Megan as master, or I don't know, mistress of ceremonies. Okay. Okay.
Whatever it is, I'm moderating the session.
Okay. Thank you.
It is a real honor to moderate this particular session. These panelists are just national leaders, have huge impact on local and national levels. You've got a powerhouse of a panel here, and it's just a real honor. As Vijay said, this session is really about new crisis models. Now, we've been working on crisis for quite a long time, and the session will really go with kind of a national view, and then we're going to have a lived experience view and a local view, and then the state view from Utah as well as Georgia. So we hope that you get a spectrum of experience and dimension about what new crisis models are available and the direction things are going. As you know, 988 is in law and will be implemented July, or officially active July 2022. So this is real, it's happening. And so we hope that you gain real insight and practical knowledge from this session. So our panelists today are Laura Evans, Tonja Myles, Doug Thomas, and Judy Fitzgerald. Laura Evans currently serves as the Director for National and State Policy for Vibrant Emotional Health, administrators of the National Suicide Prevention Lifeline and the Disaster Distress Helpline. In this role, she oversees a portfolio that includes many facets of healthcare policy, including suicide prevention, appropriations, telecommunications, and 988 implementation. With over 10 years of experience in health policy and government relations, Laura is proud to have begun her career in the Ohio General Assembly. Tonja Myles is an ordained minister, community activist, peer counselor, veteran, subject matter expert in mental health, untreated trauma, a faith-based approach to substance abuse recovery, and sought-after counsel for community-based and system approaches. She promotes mental health awareness and rehabilitation with sharing her life experiences being in recovery from addictions for over 36 years, suicide survivor, victim of childhood and adult sexual abuse, and diagnosis of PTSD. Her story is shared in published books, magazines, documentaries, featured talk show guests, and national television series. She is a passionate advocate of humane and ethical treatment of individuals with mental illness, substance abuse, sexual trauma, domestic abuse, and those formerly and/or incarcerated. Doug Thomas has served as secretary for the board of directors for NASHPID. He is the director of the Division of Substance Abuse and Mental Health for the state of Utah. He also serves on the boards of the National Suicide Prevention Lifeline, the National Association of State Alcohol and Drug Abuse Directors, and is an active member of the Utah Substance Use and Mental Health Advocacy Council. Doug has worked in the mental health and substance use disorder field for over 26 years in various capacities as a direct service provider and administrator. He has worked in both urban and rural settings and initiated the current State Suicide Prevention Coalition, which takes a public health approach and utilizes local coalitions throughout Utah. He worked as a member of the Commission on Criminal and Juvenile Justice to revolutionize Utah's criminal justice laws, especially with regard to individuals experiencing substance misuse or mental health conditions. He emphasizes screening, assessment, and cross-system collaboration to achieve shared goals. Doug is passionate about prevention, early intervention, crisis services, and integrating these efforts into systems to produce lasting outcomes to reduce risk and increase the mental and emotional well-being of individuals, families, and communities in Utah. Judy Fitzgerald was appointed Commissioner of the Georgia Department of Behavioral Health and Developmental Disabilities, DBHDD, in 2016. She has been with DBHDD since 2012, previously serving in the roles of Chief of Staff and Deputy Commissioner. Judy is a social worker with a career-long focus on behavioral health and public service delivery systems. Prior to joining DBHDD, she worked in a variety of health and human service settings, from international policy and mental health advocacy at the Carter Center to nonprofit management. Judy has sustained a passion for collaborative teamwork to facilitate positive impact to address the needs of vulnerable populations. Judy earned a master's degree in social work from the University of Georgia. Again, I just want to reiterate what a powerhouse we have today, and I hope that you'll absorb the information. I encourage everybody to ask questions at the end and follow what the speakers are saying and write down what comes to you for comments and questions. I'm going to turn this over to Laura Evans. Thank you, Laura.
Thank you so much, Megan. And I just want to say it is my honor to be a part of this panel. So, I'm very thankful for the National Dialogues on Behavioral Health. Thankful to you, Megan, my fellow panelists, for everyone here today. I hope that we'll have a really great discussion, but this is, I think that a lot of the work that will be done, that is being done, is because of conferences like this, the opportunity to dive deep. And I'm looking forward to maybe going to New Orleans as well. So I'll just, okay, perfect. The slides will come up there. And again, I'm Laura Evans, Director of National and State Policy with Vibrant and Emotional Health, and Vibrant is the administrator of the National Suicide Prevention Lifeline and the Disaster Distress Helpline. So if we go to the next slide, I also just want to let everyone know that the content that is expressed here is the viewpoint of Vibrant Emotional Health, and may or may not necessarily be those of SAMHSA, CMS, HHS, or the US federal government. So all of this is from Vibrant's viewpoint in our experience as the administrator. And so I just wanted to kind of start kind of at that kind of top line level of what is 988. We talk about 988 in various settings, and essentially, if we look at the federal law that designated 988, it is the telephone number to reach the National Suicide Prevention Lifeline. So, of course, when we mention 988, in the most strictest sense of that word, it is simply the number to reach the Lifeline. Currently, the Lifeline is a 10-digit number, 1-800-273-TALK, or 1-800-273-8255. But I think we recognize that there's a little bit more to 988 when we talk about the opportunity. And the FCC in their report and order for 988 kind of alluded to that, in that, this is the number to reach the Lifeline. As Megan mentioned, it will be, telecom providers have to make this operational by July 16, 2022. And indeed, many wireless providers have made that available. We're still encouraging folks to use the full 10-digit number, 1-800-273-TALK, just because landlines are not all uniformly able to access the Lifeline through 988. But in its most strictest form, this is simply a way to reach the existing National Suicide Prevention Mental Health Crisis Hotline that already exists and will still exist after that date, after July 16th. So if we go to the next slide. So that leads us to the next question. Well, if 988 is the phone number for the Lifeline, then what is the Lifeline? And so the Lifeline was established in 2005 because there was no one telephone number to reach a 24/7 crisis line in the United States. So it could vary by your county, if that was accessible, if your state had a crisis line. And so the mission of the Lifeline is to reach and serve all persons who are at risk of suicide, through a network of crisis call centers. And of course, crisis call centers are able to join the network, provided that they can meet clinical standards. And so I like to think of this as anyone, anywhere, anytime, and also everyone, everywhere, every time, knowing that there is emotional support on the other side of that. And you're able to reach the Lifeline by calling the full digit number. You're able to text currently the 1-800 number and reach a crisis counselor. And then you can chat online. And so, this infrastructure exists now. This will be the infrastructure, the basis for 988, as mentioned earlier. There'll just be increased accessibility. So instead of having to remember a 10-digit number when you're in a crisis, you're able to easily recall 988 and hopefully be connected quickly to a crisis counselor. So if we go to the next slide. I just wanted to provide some numbers for the Lifeline. A lot of times people may not be familiar with the Lifeline and they think, well, okay, so it's a national service. That means there's one call center in DC or New York. And that is not the case. It is a collection, a network of independently owned and operated crisis centers that are independently funded. They do receive a small stipend for joining the Lifeline, but many of the centers are, funded through private donations. Some centers, certainly not all, receive some form of state and local support and/or local support. Since its inception, the Lifeline has answered over 20 million calls, have received over 20 million calls. In fiscal year 2020, there were 2.4 million calls received. And this is just calls. This is not including the chat or text. Again, we have over 180 centers in the network. 9 of those have additional capacity and they serve as backups for overflow calls. So essentially you'll see here in this diagram that there is a how the flow of the call works. An individual will call the Lifeline. They'll hear a greeting saying, if you're a veteran or calling in regards to a veteran, press 1. They're then connected to the Veterans Crisis Line. So they leave the Lifeline network and then enter that network. If they have the option to press 2 to be routed to a Spanish subnetwork. So call centers that are able to speak fluently in Spanish. And then if they do not press 1 or 2, they are routed to the nearest call center serving their area where their telephone is. And that local center has roughly 30 to 60 seconds to answer the call. And if that call is unable to be answered for whatever reason, and again, the crisis centers are doing their best to answer all calls, and there has been an increase in demand from 2005 for services. So, the centers are trying to take every call, but for whatever reason, if they can't answer within that time frame, that call is pulled back and then rerouted to one of those 9 national backup centers that have additional capacity. But there is some connection lost. Obviously, a local call center would understand those local crises and stressors better. Certainly someone in Florida may not understand what it's like in Kansas. Connection to local resources that are available, knowing, hey, there is actually no public transportation to get to this, additional area. So there are some issues we would prefer calls be answered at the local level. We have 30 crisis centers that comprise our chat network, 5 for our texting network, 3 of the Spanish sub-networks, and then of course, a Veterans Crisis Line backup. So just wanted to give an overview of the current state of the Lifeline network. And again, it really does represent the mental health safety network for folks who are in crisis. These are individuals who are likely engaging in some way with the crisis continuum in a state. And so making that initial call to the Lifeline itself is the intervention. In a lot of cases, I think 80 to 90% of calls are able to be resolved and de-escalated over the phone without the need for a mobile crisis team or other in-person intervention. And so this just all goes to show that why the Lifeline is effective. And if we go to the next slide, there's additional information around Lifeline effectiveness and why it was essentially kind of chosen to be the infrastructure for 988, or this why a 3-digit number was needed to increase accessibility. And we know that when individuals are in crisis, sometimes there's a knee-jerk reaction. The number that is 911. And so the way that we have invested in physical health, also wanted to have that investment in mental health crisis, suicidal crisis. And so having folks being able to recall a 3-digit number more easily than a 10-digit number, we are able to hopefully save lives. And again, 90% of folks report just making that call stopped them from killing themselves, de-escalated their distress, and helped keep them safe. So just wanted to share some of that kind of baseline information regarding the Lifeline. Next slide. So we know 988 will be here operational July 16th, 2022. That's when all the telecom providers have to make 988 accessible across wireline, across wireless. And so while the Lifeline structure will operate in much of the same way in that individuals will be connected to crisis counselors, a greater awareness of 988 and the Lifeline interventions and services will be available. And so Vibrant has modeled out what that could look like in various scenarios. And this is with a marketing campaign. Again, so currently, in 2020, there were, I think, 2.4 million calls received, as noted on the previous slide. And so we just said, what are the various scenarios in a high volume scenario, medium scenario, low volume scenario? Could we expect, how can we expect that call and contact volume to change? So this includes both calls, chats, and text. And so we have sort of that baseline volume and then thinking around kind of what the percentage of calls that currently come into 911 or other crisis lines would now be coming into 988, because that's either the most appropriate place for them in cases of 911 and awareness to kind of with the 3-digit number ease. And then the new volume, so people who are currently in distress and are not being served. And so if we look at that, that can be anywhere from around 6 million contacts in the low end to 12 million contacts in the high volume scenario in that first year alone. Again, this is coupled with a marketing plan, so that would be contingent on marketing of the number. And so even if we kind of look somewhere in the middle around 9 million contacts, that's a significant need to build capacity currently. So going from answering 2.4 million calls in 1 year in 2020 to in 1 full year of 988. So from July 2022 to July 2023, answering from 6 to 12 million. So that shows there's a significant need to build capacity within the network at the crisis centers. And that can come from building and investing in crisis centers and ensuring that we are including perspectives like the lived experience perspective and building out pieces so that we are serving various communities, marginalized communities well, who may not always be receiving the supports that they need. So this is Vibrant's analysis. Of course, we're still waiting to see what SAMHSA comes out with, but we just based this on our experience as the administrator and what we anticipate could come in. Next slide. And so really 988 again is this opportunity, right? So it's not just the telephone number shift, but it's the opportunity to reimagine crisis services in a way that actually serves the individual in crisis well. Currently, you know, I'm sure any number of us could speak to issues in the current system and fragmentation. And so I think this is really an opportunity when we're talking about new models to think, how can we coordinate these services and ensuring that we are kind of moving folks along the continuum and doing that in the least restrictive environment. And so from our perspective, you know, this is all really hinging upon the crisis centers that are in the Lifeline network, being that someone to talk to that SAMHSA has identified as part of their three-legged stools of having someone to talk to, someone to respond, and a place to go. That again is reducing reliance on law enforcement, that is reducing reliance on jails or hospital emergency departments. And so from our perspective, that the kind of the crux of that is the crisis centers, because if we can divert 80 to 90% of individuals in distress from needing someone to come out, then that also prevents them, you know, being in jail or needing a place, you know, kind of moving up the scale there. And so kind of thinking about this of how can we ensure that we are coordinating both the mobile crisis teams and the crisis stabilization units, providing information around the local resources, providing the follow-up services, which a majority of our centers in the network do or have contracts to provide those services. So how can we do all of that using this opportunity that 988 represents and kind of build that capacity to allow the centers to do the great work that they do. So I think that's kind of sort of our question as Vibrant in our perspective of how can we ensure that we are having a really large front door to the crisis continuum, as well as serving people at that initial point that we can in preventing additional costs and criminalization down the line. So when we think about that, we also kind of have some of these questions, and I know a lot of states are working in their Vibrant 988 planning grants to answer some of these questions. These are some of the questions that we're hoping state legislatures are considering as they kind of introduce legislation, because I think that is kind of the crux to this whole endeavor, this whole opportunity that 988 represents. Next slide. So one of the items, because this does take funding within the federal bill, is this ability for states to levy a fee. I've outlined the entire section from the federal law. So this is as it reads in federal laws here. I'm not going to read this to you, but it essentially says that one option for states is to levy a fee very similar to how 911 in many states receive funding. And this is, from our perspective, this should be in addition to, so this should not supplant, but this should be braided along with state funding, federal funding, you know, the mental health block grant, all of the various levers and mechanisms, you know, should be a part of this conversation. But I definitely encourage that a fee is also a part of the conversation, because we know that in 2020, the 911 fee generated over $3 billion in 1 year. And the year before that, it generated over $2.6 billion. So again, you know, that's certainly nothing to sneeze at when we talk about crisis services and historically systems that have not had that level of investment, and how we can use that funding sustainably to both support crisis centers and help prevent people from getting to a point where they're in crisis. So next slide, please. A quick overview of the state activity And many of you who are on the Crisis Jam may be familiar with this map. This green just represents states that have signed into law pieces of legislation that connect the continuum. Not all of these states have a 988 fee, but they do have some sort of legislation that would coordinate the crisis continuum. Michigan should be highlighted here, and I apologize that it is not. They recently introduced legislation last week. So there is some effort, there's some movement to do so. And then there are many states that are not highlighted here that are still, again, in the planning process. So they may not have official legislation introduced, but that doesn't mean their agency isn't doing something. And so it's just really important to ensure that you're talking with both the agency responsible as well as policymakers who may need additional time to be primed to understand all of this is going on. You know, I've heard from folks of like, oh, 988, that's a telephone change. We don't need to do anything. And in one sense, that it is true. It is a telephone change that will happen, and a state doesn't necessarily have to do anything, but it would be a real missed opportunity to not leverage that to connect the continuum and serve people in a way that we haven't, right? Like we have to change this from a fragmented system to a coordinated system, more coordinated. And certainly, I think it would behoove a state to ensure how they can do that. Because again, these are people that are likely engaging in other areas of the continuum. And so if we can help them and keep them in the least restrictive environment as possible, then I think we also are saving money on the other side. Next slide. This is just kind of an overview of states that did enact a fee and their anticipated revenue. And again, this does not mean that other states have not invested in their crisis centers, building out mobile crisis teams. This is just kind of a snapshot of the fee. I know there are many states that are putting money towards this during their general budgeting cycle. But I just wanted to show this to show kind of what is possible with the fee. And again, it should supplement, not supplant. And again, how a fee could be used in ensuring that when we are talking about priorities, right? Like a state's budget always indicates their priorities. And so ensuring that we are thinking about that front door to the system, the crisis centers and the investment that they need, and building out mobile crisis teams, because for those individuals who do need someone to come out, that in-person intervention, crisis centers are often left to see, well, what's around? There's no mobile crisis teams. Unfortunately, that may mean law enforcement. And that doesn't always help a situation. So again, making sure that we're building out mobile crisis teams and having places for people to go. Next slide. And of course, I think a lot of this will be dependent as well on the federal funding. The feds are not off the hook because they passed the law. And so we see here kind of some of the funding mechanisms available at the federal level, including funding for the National Suicide Prevention Lifeline itself. That funding is used to ensure that there is, training and standardized experience across the Lifeline network that ensures that every call, chat, and text is free to the end user. And so you'll see there's a large jump there from the fiscal year 21 budget, which we just ended at the end of the September, was 24 million, which is an increase from the previous year of 19, to jumping up to roughly around 100, 113 that's under consideration. So this is a huge investment. And, again, that is towards some of that anticipated call volume, keeping that free, the routing. So there's still a need for investment. Although centers will get a stipend, there's still a need from states for investment in that. The mental health block grant had a 5% set aside in fiscal year 21. We're looking at potentially a 10% set aside for fiscal year 22 once Congress is able to come to a agreement. Currently, we're working under a continuing resolution. So both chambers have not agreed on funding levels for the entire year. And then we have the CCBHDs, another mechanism for folks. And then one-time spending through various COVID packages, American Rescue Plan. There's some funding in the Build Back Better, but of course those are, that's still under consideration and not finalized. So we can go to the next slide. Of course, you know, again, we believe that this should be a braided approach, you know, both for the Lifeline network operations, the crisis centers, and the mobile crisis and the rest of the continuum, and that they should include all payers at the table. Next slide. So again, I think, you know, I wish I had answers for today, but I just, you know, I think we all want to meet this vision that 988 and potential that 988 has when we're talking about the continuum, you know, thinking about how we can build capacity, how can we ensure that there's sufficient funding. I didn't even get into funding for the workforce because that could be a whole other session. And then, you know, again, coordination across the continuum ultimately to serve those who are in crisis. So I will stop and again, just thank the National Dialogues on Behavioral Health, Megan, and my fellow panelists. Very excited to hear what discussion comes out today.
Laura, thank you so very much. That was a fantastic overview to really set the context for the rest of the panelists and discussion. So thank you very much. We're now going to move to Tonja Myles, and take it away, Tonja.
So first of all, good evening, good afternoon, wherever you are. Thank you guys so much for having me. Thank you so much, National Dialogue on Behavioral Health, for having me again present. I remember when I first was introduced to you guys by Dr. Jan Kosowski many years ago, and how I was just so grateful to be in the room with such prestige and amazing people. I was really, really excited and overwhelmed, just like I am right now, to be a part of this dialogue and to be a part of this panel of amazing people who for real do the real work to make sure that the work that they're doing, the tables that they are at, all of that information and that help gets to the people who needs it, you know, on the street or wherever they may live. I'm so glad we're having these conversations. I think about what the great poet James Brown had a song and it said, talking loud, but ain't saying nothing. Well, nobody has time for that, period. Particularly now, we're going through so much in our communities and countries, and people are having so many crises after crisis. And now we're talking about trauma, and we're having these great conversations. So I'm grateful that you guys are always at the forefront of talking about things and kind of seeing things of what could happen and the promise of what could be. And the fact that we're now sitting here almost at the at July 2022, when 988 is going to happen, and how much work we've done, but still how much work we have to go. And that's why we're having these conversations. And I'm grateful to that. Laura said something that really, you know, kind of hit me. She said this, she said, opportunity of a lifetime. And this is an opportunity of a lifetime. And I'm grateful that I'm sitting here and I'm able to hear that these systems are being built and things are coming into place, and conversations we had 5 and 6 years ago are now actually happening, and we're starting to see some things. An opportunity of a lifetime for us. But I think about the opportunity of a lifetime for people that we serve, that they can now live a life, that they can know that it's going to get better, that one decision of maybe, you know, contemplating suicide or taking their lives, that we can be that beacon of hope so they can be here for their lifetime. And so it's going to take us continually, collectively working together. As a peer support specialist, as someone who's in recovery and an outreach pastor, I love what I do. I wake up every day on a mission to push hope, for real, for real. I'm grateful that I get to do this work every day. Most days I kick butt, but a lot of days I get my butt kicked. But I walk out of this door like I'm going to save the world every day. And I believe that. I have to believe that, because so many people are going through so much. And when we talk about crisis and 988, I'm glad we're going to have that designated space or that number we can call, but it's necessary that we have a continuum, like Laura said, that we have those spaces and places in place, that when the person makes that call, that we can get them the right resources, get them the level of care, get them the hope and help that they need. Because if not, then, you know, we've done the people that we serve a discredit. And so I've been on, you know, suicide runs in my community. I've been on phone calls with family members, you know, walking them to what to do. And unfortunately, depending on what zip code they live in, their experience is going to be a little different. If they live in the country club, their experience is going to be a little different. You know, if they from the curbside, their experience is going to be a little different. So the ability to have 988, and we already, you know, have amazing people who are doing other work. I'm not discrediting anything else, but I think this will be a game changer because, you know, the people that can come will be called to do this work, will be credentialed to do this work. And I'll talk about that in a little bit. So I've been in spaces where it didn't go well because law enforcement didn't know what to do, or EMS didn't know what to do. And that person end up didn't getting the help that they need. And so the fact that we'll be able to see that done different by mobile teams and things of that nature is a game changer, you know, for our community. But again, you know, we have to have that continuum in place. If not, like I said, we just created this beautiful number that kind of goes nowhere. We're not going to let that happen. I know we're not, you know, so seeing those things happen and having mobile crisis teams available is a game changer. Making sure that law enforcement through CIT training, like they get that training, making sure we have buy-in from law enforcement, make sure we have buy-in from everybody, because we're going to need everybody working together, everybody playing in the same sandbox. And so as we continue to have these dialogues and discussions, we have to continue to get, you know, buy-in. And I know that, you know, you guys who are on this call are already, you know, doing this amazing work, but we even have to do a better job of getting the buy-in from the community, particularly for people who don't normally would call a crisis line. Look, the crisis line is an amazing thing. It saves a lot of lives and it's already doing good work. And this is just going to make it even better. But we have to make sure we get the message to people who normally historically does not call a crisis line, particularly African-Americans. We don't do crisis lines. That's just not our jam. That's not what we do. It's not what we're told. We can't tell everybody our business. We don't know who's on the other phone, on the other line. So we still have some work to do when it comes to messaging about, I know we talk about the promise of 988, but also the hope of 988, the hope that when a person calls, we know that they're going to get that, you know, that warm voice. We're making sure that after they, you know, get that initial assessment, that they then they're routed to those local resources that we were talking about earlier, that's going to get people the help that they need. And like I said, buy-in from everybody, from our state reps and local organizations, because again, you know, it's not free. Saving lives are not free. You know, people sacrifice their life every day to save lives, be it, you know, vets, or be it people on the street, or be it, you know, healthcare providers. Everybody's sacrificing. So we have to sacrifice as a country and a community to make sure that 988 and crisis continuum is always into place. I've seen too many people who needed to go to treatment, go to jail. I never forget when the executive director of LG, Capital Human Services, she asked me about, I think in 2013, you know, I need some help, you know, because I don't know where my clients are. And I'm like, oh, I know where your clients are. They're in parish prison. And so being able to take her there to talk to the warden and things like that, having dialogue changes things. And so making sure we always have those times where we're talking to each other. Again, making sure people buy in, we have to do that. And so this will be a great way to divert people, you know, of course, we all know that instead of going into the, you know, prison system or the jail system, now they'll be getting the help that they need. And that's the beauty of all this. Again, like I said, I've seen so many people, you know, make those phone calls or call people, said, look, I'm in crisis. I don't know what to do with my family member. I don't know what to do. And not being able to connect them with resources because there was none that were, you know, pretty much talking about true crisis. It's really sad. And you see people not get the help that they need because there's no resources out there. So the fact that, again, you know, we're having these conversations, we're doing this dialogue, and we're making things happen is just amazing. Let me just say this. I love doing what I do. I love training. I love talking to people about trauma and about crisis. And when I started talking to law enforcement during their CIT training, many years ago, it really was moving for me to do that. Not only because I'm a vet, just particularly for 9 years, I was a I was a military police. So I understand, you know, their language. I understand, you know, their drive. My mother-in-law, who was also 35 years law enforcement, married to her son, and just seeing the things that she went through and just how she loved to serve. You know, I have a heart, you know, for those who do that. But, you know, the fact that we still have a lot of police officers across the country, or sheriff, or other people in law enforcement that are not trained in CIT, you know, are conversations we have to continue to have. And so when police officers are trained to de-escalate when they come in contact with someone who's having a mental health crisis, again, that's just a win-win for the people that we're serving. So we know that that's not going to happen, that a lot of law enforcement is still not trained, but to have mobile crisis team where people are trained, you know, to meet the needs, who know how to talk a person, not only in a, you know, compassionate and caring way, but know how to de-escalate again, and also connect them to the right resources, because we have to continue to do that. And so about in 2015, I became my own crisis. You know, I love helping people in crisis. I do it well. I really do. And it's not something I'm bragging on. It's just something that I was called to do, particularly because life chose me to do it. In 2015, my husband and I were having some challenges in our marriage. And so I separated and I left. And when we separated, nobody knew, probably maybe like 5 or 6 friends knew, because people in the back of my mind, people always said, Tonja, you know, if something ever happened in your marriage, it's probably going to be your fault. And the reason why people said that is because my husband is a really good man. I'm the most traumatic thing that has ever happened to my husband. I'm gonna own that, y'all. I am. He's a good man. He's really nice. He's real low key. If you know me, you know, I can be all over the place and I like to see people smile. And so they were like, you guys are just totally different. And we had a counselor who told us, because my husband and I had to get extensive counseling because of, you know, my past with drug addiction. I've been in recovery for about 38 years. When I was 7, I was sexually molested. When I was 10, I started using drugs. I was also sexually active. The first time I tried to kill myself, I was 13. I ended up in a hospital, getting my stomach pumped. The second time I ended up in a mental hospital. And again, through all those times, nobody in my family ever talked about me wanting, you know, to kill myself, always living to die, because that's basically what I did, and having 2 suicide attempts. And, you know, being so strung out on drugs, they knew that they had to help me in that way, but nobody kind of talked about the mental health part of what was going on with Tonja. I had an uncle, his name is Uncle Larry, and he's schizophrenia, bipolar, and HIV. And people in my family, always told me, you're going to be crazy like your Uncle Larry. So I'm just like, okay, that's my fate. So with all the trauma that happened to me at 7 years old that went untreated, because my parents didn't know what to do, we were just told, you go to church and, you know, you keep it moving. And of course, you know, that got worse. And so I act out a lot. And like I said, you know, marijuana came into pills. Pills turned into cocaine. Cocaine was full on, you know, crack. And I hated myself. I hated the life that I live. When someone introduced me to prostitution, I'm thinking, I'm giving it away. Might as well get paid for it. And that was my life with prostitution. I was basically a call girl. You know, if men had money, then, you know, I had what they needed. And every time I did it, I thought I was, you know, in control of men and kind of getting back at them. But that was not happening. Every time I did it, it was just taking way more of my self-esteem. And it was a slippery slope that I didn't know how to get off of. And so the last time I did try to, you know, to kill myself, you know, I didn't want to live. I was done. I'm like, I can't even kill myself and be successful at it. And so thank God for a grandmother who, you know, kept praying for me and continued to encourage me to let me know that there was a plan and purpose for my life. And that was 30 something years ago. And I haven't looked back, and I made a vow to God, if he helped me, I'd help others. And so that's why, you know, this counselor said, I don't, you know, Tonja, you know, if something happened between you and Darren, it'll probably be your fault. So that's always been in the back of my mind. And so when my husband and I separated, nobody knew. I went and stayed with a friend of mine in their guest house. And so it was not a good 6 months. And by the time I thought I was ready to go back home, things weren't working out. And, you know, I'm like, I'm done. I'm tired. I'm tired. I've lived a good life. I want out. And I wrote a suicide note, 4 pages. And I after I wrote the note, I took my medication and I went to find a park that my family could find me, because I didn't want to prolong them not finding my body. And I just wanted them to lay me to rest. But I wanted my family to know that I was tired, that this was my fault. If loving me was enough, I know I'm loved, but I'm tired. Wrote the note, went to try to find a place, but I called a cousin who had PTSD, and he had just came from, he was just, he had served 25 years in the military, and he just retired. So I'm like, he's gonna understand what I'm going through, and he can convey to my family that it's not their fault, it's all mine. And so what I thought he was gonna do, he didn't do. And so I ended up getting a phone call and a visit from my nephew. My nephew came to the house on a whim. My nephew walked, the door was open, and he was like, this is odd. So he walked in, he saw pills on the floor. Now this is his account later, and he found the note. When he found the note, he called some family members, and my nephew then called the police. How did he know to call the police? Because he had been on runs with me before, and he saw me do this very thing that I'm doing now. And so when Trey called the police, he also called some other friends. I was about to turn my phone off, and a friend called in. For some reason, I answered it. I kind of had to come to my moment self. About an hour later, I turned around. I said, I'm going back to the house. When I went back to the house, I turned right, and there were police. I couldn't turn around because they spotted me. So I had to go there, and I got out the car. Now I'm a peer support specialist. I'm a pastor in the community. I'm a community advocate. Everybody knows me in the community. I do TV and radio, so I got this. So I get out the car, and I'm going to talk my way out of the situation. So I thought. And so the first officer who approached me, he asked me, my name, and I told him, and I said, look, I'm just having a bad day. Me and my husband had a little issue, and I'm good, and he's like, no, Miss Myles, you wrote a note, and people are concerned about you. People are looking for you. I'm like, well, I'm good. And then I'm trying to drop names and everything. I'm like, I was just with your boss. I'm like, you can call them. I'm good. And so he went to the phone. He said, let me make a phone call. Then another officer approached me. This officer was rude. He was arrogant. And he treated me not like I was in crisis, but like I was a criminal. And so I had enough, wherewithal for a minute to think, okay, this guy here is not making this better. And so I felt myself getting more angry. And I thought, you know what, this will be a good way to die. Suicide by cop. Being a vet, that's what you want to do. So I knew I could even provoke him anymore. And then he would just go ahead and shoot me, and what I wanted to do has been done. But then I looked over to the left, and I saw my nephew, Trey. And I'm like, I don't want to see Trey see me, shot in the street. That's not what I want this kid to realize the last time he see me. So by then, the other officer came back, and he can tell I was struggling. Because I asked him when I came up, I'm like, are you CIT trained? And he's like, yeah. And then he's like, I know you. And I'm like, okay, yes, we're going somewhere with this. And again, I was going to talk my way out of it. And so that CIT trained officer, when he came back on the scene, he was trying to de-escalate me because he knew what was about to happen. And so he was able to get me focused on him. He said, look, Miss Myles, we're going to have to take you to the hospital. I'm not going to put you in the back of the car. I'm going to let your nephew take you, but I'm going to follow you there because you wrote a note and people are really concerned. So I went to the hospital that night. Of course, they admitted me because I had a suicide note. I, was again put back in a mental hospital where now my friends were able to come and see me. And the look on their faces as I'm sitting there, they're looking at me scared, hurt, and broken. And I realized, Tonja, this pain that you have in all these years will not die with you, but it'll be transferred to your family and friends. And that was a wake-up call. The other thing was a wake-up call is after that incident was the first time I went to counseling, a licensed therapist. And that was 6 years ago. And for the first time in my life, I'm not going to tell you how many birthdays I have, but in the first time in my life, I have not had a thought of suicide in 6 years. And that has never been, it has always been in my back pocket. Suicide has always been an option. And so I say that, and I go back to what Laura said, opportunities of a lifetime. That's what we're doing when we make sure that 988 and crisis continuum, as we build this amazing, amazing program, this amazing system, that we realize that we're giving people the opportunity of a lifetime to realize that it does get better, that there is hope, that there is help. And that's what you guys are doing. And that's why we have to make our voices real clear to all our elected officials and all those in authority that this is going to work in our lifetime, because we have to save lives like never before, because people are hurting. People think the only option that they have is death by suicide or destructive behavior or living a life of crime and substance abuse. But we have to make sure that as we build this system, that we're making sure we have everything in place. And we know it's going to take a minute, but we're not going to give up. We're almost there. The promise of 988 is now the hope of 988. And having these dialogues, having these discussions, making sure we get buy-in, make sure that we having that crisis continuum on every area to help people. And I'm so glad that the panelists that you're going to hear from, you know, they're like me, they're passionate. They want to see lives change, and they want to share all the information that they know that other states across the country, no matter where you are, that you'll be able to have a great continuum of care that will help people like me. Because it worked that night. It almost didn't. And again, I've seen it not work even in my work today, but I'm not giving up hope. I know that we're all going to get this done. And in our lifetime, we're going to build a system that's going to help save lives. And that's going to give us the opportunity of a lifetime to make this happen. But more than that, give people the opportunity so they can live a good life. So like I said, that they can be here for the better. And they can then go and spread the message of hope that trauma is real, but so is recovery. Life happens, but there's hope. So I want to thank you guys so much. And I'm excited. And I hope you are too. Thank you.
I just want to take a deep breath, because Tonja, what you've shared is so incredibly moving. And I imagine we have loved ones, or personally, we've been through something similar. And just thank you for sharing your story. And I can't wait to talk with you more about it. When I think about you talking, I wonder if 988 were in place, what 988 would have done, what mobile crisis team, how that would have played out, maybe crisis stabilization after that. So when I think about your story, it's like I run it parallel from what happened, and thank goodness you're here, to what can happen and it would work in an even more constructive, compassionate way. So yeah, thank you so much. We're now going to move to Doug Thomas.
Thank you, Megan. And I knew it was going to be hard following Laura and Tonja. I didn't know that I would, it's a good thing my camera isn't that high quality, because you can't see the tears, and you can't, I just feel like saying a little hallelujah and amen to what Tonja said. And Tonja, thank you for sharing your personal story. It's what motivates us to continue the hard work every day when we are able to hear stories. Like yours, of hope and recovery. That's what it's all about. So thank you. I'm really grateful to be here again. I was at this conference a long time ago, and got to speak about integrating prevention and early intervention into the work, and I feel like I'm kind of doing that again, but now it's with crisis services, and getting upstream in the crisis work, and then making sure that we have a continuum of care to really link into and that we have the supports in place for people when they do access services this way. Unfortunately, we're still a little late to the game in behavioral health. We're not getting upstream fast enough, and people don't know they're in trouble until they're in trouble, and that they need help until it's a crisis often. And some of that's stigma and discrimination and a lot of other things tied into that. And so, you know, those are some of the things that I think we're going to address today. So I think my slides should be coming up soon. Okay, here we go. So next slide, please. So as Tonja was saying, there's we all know where people access crisis care right now today, and right now those are the places where they're overwhelmed. There's workforce shortages. They're not equipped to deal with people in psychiatric crisis. That's not what they were built for. It's not what they were made for. But that's where we know to go today. And so we often end up in places where we receive the best care we can, but it's not always the right care at the right time, individualized for the person. So next slide. The same thing happens on the law enforcement side. They've been the ones, like Tonja said, who are the ones who typically have been asked to respond. And we've done things like CIT and other things to help them have better tools. But really, we just needed different people to respond to behavioral health crises. And until now, there really wasn't a vision or a system that imagined how we could do that comprehensively across the United States. And that's really the hope and the promise that 988 has. You know, they're having workforce shortages too, and now they're seeing, hey, I'm going to have a lot more options where sometimes I'm not even going to need to go on a call. Sometimes we do need the police there and we need co-responding. And so we have to be good partners and have good training for each other so that we understand their language and their protocols and that they understand ours as behavioral health. And giving them options where they can get back out on the street faster, that's what they want to do. They want to be there for the public safety as well. And the behavioral health stuff is our area of expertise, and theirs is a different niche. So next slide. So I know this group shares this vision, right, of wherever someone, whenever someone may need it, that they can just access the care they need. Next slide. The way we've tried to think about it in Utah is we've been working towards 988 over the last probably 6 years or so, is thinking about it as a system that addresses all of these things, the structures, the processes, the services that help meet people's urgent and emergent behavioral health needs. And we don't want to get too narrow in defining what crisis is, because people define crisis differently. Different populations define crisis differently. And we don't want to limit it and make people think they can't access care or services. In addition to that, we do need to have ways to respond differently in different geographies. We've got urban areas with lots of population, and then we've got rural areas and that have populations spread out over many, many miles. So having some flexibility in our system will be important as well. Next slide. So we commissioned a report from RI International, and then our hospital association, we partnered with them to commission a behavioral health system, and it's really pretty focused on our crisis system. And these two reports really helped us to take a look at where we were, what the gaps were in our treatment and recovery supports and subacute crisis and crisis response. And so we had some data and information that helped drive us to make some of the decisions that we made for our state. And each state is different. If you've seen one state, you've seen one state. So your needs and gaps analysis is going to be different, who your partners are, where your strengths and weaknesses are. And so I think that's just an important part as you're thinking about doing this in your community, in your state, really understanding the resources available to you. Next slide. On this one, this is just kind of a little bit of a timeline when of our involvement over this process. So in 2012 is when we went to a statewide crisis line where the state was actually helping pay for the service, and then starting to think about how we could really coordinate a crisis response system statewide. And there have been some important developments along the way. We've had an app, the Safe UT app, that's a crisis text app for youth that was launched. It also has some reporting features for school safety and some other things built into it. And we started talking about a 3-digit crisis line at that time in our state, which then ended up, as you know, becoming the national legislation. So we started thinking about building around this 988 and a crisis number rather than just a suicide prevention specific number, because we know not everyone was yet suicidal. Some people were in crisis and pre-suicidal. So were they going to think, okay, this line and this number and this help is available for me? And we wanted to make sure that it was. And then we've passed some different laws in our state and then federally that have been passed. And this just kind of gives you the timeline as we've built this out. And we've tried to get in there for specific communities as well. So some of our apps, that Safe UT app was really targeted at school-aged kids, K-12. And then we've done some rebranding of it to be available for our National Guard, for our first responders, and for healthcare workers with the COVID crisis, so that they have a response and a way just to get that kind of help, which will also be available with 988, as we'll have a text capability there as well. Next slide. So the Behavioral Health Crisis Commission was started in Utah about 7 years ago, and it's changed its name three or four times because the committee is trying to hone in on what the right name is. But over time, it's had these people involved giving input into what a crisis response statewide looks like. And I just want to point out that it's really important to have policymakers, but it's really important to have people with lived experience. And it's really important to have payers. And it's really important to have just a diverse group to talk about how this should roll out, how it can best be set up to meet the unique needs of your state. So this is just an idea of what we came up with. I'm sure your listing will include a lot of these and also have other players that are important. Next slide. This is one of the House bills that was first introduced, where we started to codify things like mobile crisis outreach teams. And we started to put requirements in place for crisis receiving centers, for certified crisis workers, things like that, setting standards that aligned closely with the national standards that Vibrant and Lifeline and others had in place, as well as best practices with the emerging science, what we knew about crisis response, and putting those things in place so that when you would show up in one area of the state, you'd have a similar response showing up, in an urban area or a rural area. The training would be similar and the standard would be similar. So we know that there's a lot of work that's been going on in this area across the nation, and really happy with the results. I was talking to a team just the other day in one of our rural communities that spans, it's about 16,000 square miles, and that's 6 counties, and the total population in those 6 counties is probably around 200,000 people. And the smallest county has probably about 15,000 people in it. They have more sheep per square mile than people. And so the crisis response system, they still have certified crisis workers there, and they are on call, as opposed to in our urban areas where they're kind of in a different model, ready to roll out. And then they can reach the licensed mental health therapist via phone or via iPad if they can't deploy, so that we have coverage and are able to respond within an hour or two, no matter where we're at in the state, as a best case scenario. Next slide. So the other thing that we also thought a lot about was making sure that people who called, who maybe it wasn't an acute crisis response that was needed, but they did need someone to talk to. They did need peer support. They did need that hand, just comforting them and talking to them and reassuring them. So we also made sure that we had a warm line and peer support specialists that were trained and certified who could offer that service as well. And then we've also submitted the Medicaid waiver to look at getting the economy of scale in place, so that we do have residential and other subacute beds in place when there's a need for that. Next slide. So this is what we call the cone. So usually when I talk about cones, I'm thinking about ice cream because I'm a foodie, but this is the crisis system cone that we talk about. And it really talks about, like Laura said, that 90% of the calls get stabilized over the phone, which is incredible. It's not a triage line, or it's not a dispatch line like 911 is, where you call in and you're just getting dispatched. You call in and you get your problem solved 90% of the time on the phone, which is amazing. And the training and the support and the standards all speak to that. But for those people who do need more, who need that 10%, having a mobile crisis outreach team is critical and vital. And so we're just, so excited. We just this last year got statewide coverage for our mobile crisis outreach teams. Our last 2 teams just got put in place, and we now can serve the entire state with this. And our law enforcement partners and our hospital system partners and others are just excited for this service. So the hub is through the call center, it's through the crisis line, but also at the local level, they're tapping into it as well and have access to it as well. And of those, about 75% to 55 to 75% of the people who get a mobile crisis outreach team visit get stabilized in the community at home and set up with a crisis plan and some follow-up, and some great things are happening there. And we're still trying to add in additional pieces. We don't have, for instance, MAT induction yet in place, but we're aspiring to that. We don't have, some things in place, but we're really gearing up for what are the next steps we need to make there as well. And then we have 23-hour observation, where we have, we call them chairs instead of beds. So they're recliners. So you can lay down, but you got to sit back up at some point. So in the recliners, we've got 2 communities that have these 23-hour observations set up, and 2 others that are building buildings right now to put these in. And then we're looking at how do we do this in rural areas? What does a rural receiving center look like? And we're talking to hospitals, and we're talking to our local mental health and substance abuse authorities about what that can look like, and exploring ideas and to some of our other states who have some rural receiving centers set up to see about those models. But about 70% of the people get stabilized there, and then there's about another 30% that need to go to subacute hospitalization or to acute inpatient. And knowing you have a continuum of care to refer to that you can also step down to is critical and important. Next slide. So our last bill that we just passed, which was the Mental Health Crisis Assistance Act, really focuses in on the crisis system and 988, and our legislature appropriated $15.9 million in ongoing funding for these services. So because they knew that 988 was coming, they put this money in and then backed half of it out. And so half of that, the full 15.9 will be available next year, right when 988 goes live. And we're really excited about the partnership we've had with our governor's office and our legislature to make this work as a partnership, as well as a lot of our providers and hospitals and others. Next slide. So this is part of what we're doing as we try to operationalize 988 is we have to look at so many different components of this. It's not just like Laura said, yeah, we got to answer the phone. That's the first thing. But then after we answer the phone, we have to have something to help people with other than just the phone for those who need a little bit more. So we're exploring all of these things and making sure that we have, that we're paying attention to the needs of the workforce, to technology, resources, marginalized populations, and the peers and those with lived experience, and how they can be a really big contributor to the success of the system. Next slide. So I've talked a lot about this, but just wanted to have this in here. Having a standard response and a standard language about risk and what it means, so that when you're making handoffs, people understand, oh, I don't have to reassess, which is a big deal and a time waster when you have parts of the system second guessing other parts of the system, right? And so as we set this up, we wanted it to be, and it's not perfect. I'm not going to give you any illusions that it's like perfect and flawless, but it is working the majority of the time, where if the crisis wasn't resolved at this level and it needs to go to the next, they're just saying, okay, let's roll and let's see what we can do to support the person and put things in place. So next slide. So we really appreciate the Vibrant 988 State Planning Grant. And this has been a great opportunity to bring together that group I showed you about before and have them help us do this. They're the ones filling this out with our staff and coming up with the plan and how we address these core areas that are so important to the success of having 988 be implemented. Because when people call in, if we don't have a good response in place, they're going to go and call 911 again next time, right? They're not going to call again if we don't give them a good response, if we don't provide a good service. And so we're really focused on being able to have something stood up when 988 goes live in July next year. Next slide. So we've talked a little bit about the firehouse model and the healthcare model, and they're kind of different models as you think of what your crisis system and subacute system and model are going to look like. And we've geared it a little different in different areas of the state based on the resources that are available, based on the partnerships that are happening, based on the funding, based on the population, the rurality, all of those kinds of factors. And so just having some flexibility and knowing what's out there is really important. Next slide. So I saw in the Q&A someone asked about this, and I anticipated that. My first one was the teaser. This I'll get into the detail now about the waiver. So we do have, with our Medicaid waiver, we do have rates for our MCOT teams when they deploy for Medicaid patients. We also have 23-hour receiving center costs. It's a bundled rate that we receive for the receiving centers, as well as we have a subacute rate for subacute hospitalization, and then a residential rate for residential, because we found out that different providers wanted to do different things in their communities. Some said, oh, we already have plenty of residential beds, we need more subacute hospital beds. And others said, well, we need more residential. So we said, okay, well, let's be flexible and allow for both. And then we're working with private insurers too, to try to figure out how we can capitalize on people that do have insurance as well, and be a resource for them. Next slide. So this is just some of the data, and you'll have access to these slides and you can look at these, but it's really supportive of the data that Vibrant and others have put out there. Next slide. And you can go to the next one as well. So really just trying to get upstream and coordinating with 911 has been really interesting. And we have some 911, we have, I think, what was the number? Is it, I don't remember, 30 call centers, 911 call centers throughout our state. And a couple of them are dispatching their MCOT team locally and have really strong partnerships even through dispatch. Others are coordinating their 911 back to the crisis line, and then the crisis line is trying to resolve and then dispatching. So we've got to, we're a really local driven state, and so we've tried to build in some flexibility for that. Next slide. These are some of the results and outcomes and strategic data elements that we thought were really important to include, so that we can show the impact of what we're doing on law enforcement, on emergency rooms, on the system, to show, look, this is not just a feel-good thing. This is a best practice thing. This is getting people to the right service at the right time, the right place, and then they don't need this higher level of care. They don't need to go to jail. They don't need to get in the justice system. They don't even need the emergency room most of the time. This is what they need. And so we're trying also to make it easy for law enforcement when they pick someone up on the street and come in contact with someone, that they can just drop them off, and that it's faster than them taking them to jail. And we give them a donut and a soda, or it's better customer service, better than they get when they go take someone to the jail. So we do have coffee and donuts and soda. It's those caffeinated, like Red Bulls, right? That's what the cops like. So next slide. And we also recognize that for the 90% of people that call in and then don't need to go to a higher level of care, they also do better when they get certain things afterwards. And so we're also on that back end providing caring contacts and outreach and warm handoff and the warm line. We also have been developing some stabilization services for children and families, so that when families and kids call, mostly it's their families that call in crisis, that we have some in-home stabilization that we can do for up to 8 weeks with the children and families, to help make sure they're not just churning back into another crisis a few weeks later. Next slide. As Laura mentioned, there's a couple of different funding options about collecting fees or general fund appropriations or different ways. In our state, The fee was seen as a tax, so it wasn't really, they didn't want to consider it. So they looked at the general fund and how to do that. And next slide. One of the risks with that is making sure that the funding keeps up with both population growth and need. We already know that there's inadequate funding in behavioral health. And so just making sure that we are addressing that and figuring out ways to overcome that in lean budget years and other things are going to be some of the things we're grappling with as a state and as a commission. Next slide. So that's all for me, and we look forward to having the dialogue later, and I'll turn it over to Megan and Judy.
Doug, thank you so much. And thank you for your leadership. I mean, how fantastic to have this statewide in Utah save lives in all the different rural and urban areas, and how you looked at the follow-up. It's just an incredible example, and just so glad you could share it with us today. Thank you so much. And we're going to have a lot of questions for you. So, I'm now going to turn this over to Judy Fitzgerald in Georgia. Thank you.
Thanks so much, Megan. So Doug, you decided to just amp it up, make the job even harder to go last. I'll tell you what, I have been furiously taking notes. I just want to thank my fellow panelists. I've learned so much, right? I feel like I've been at this for a little bit, but each of you, I think, had so much important insight. So there's more to connect on. I also want to say thanks to BJ and to the National Dialogues, and just thank you for choosing this topic, and thank you for, despite the virtual environment, remember that people are gathering this way. And I think what you heard from all the panelists is work has not stopped. So we are making connections, really, really important connections, and making important strategic plans. So I'm really pleased to be a part of it today and grateful. So Jessica, let's go ahead and pull up my slides. And I'm now going to have to repeat one of Doug's lines. That's the problem with going last. You want to talk about crisis services. You've seen one state, you've seen one state. So you heard from Utah. Now I'm going to give you a little perspective from Georgia. So every single state, and as Doug said, within his state, there's a lot of differences. Same is true in Georgia. I do want to say one thing about this, though. That is absolutely true. But here's the thing I know, I feel like from every state leader, all the commissioners that I talk to, regardless of what their continuum looks like, I know one thing is for sure. Everyone is viewing 988 as really the opportunity. This is our time. This is our launching pad. And despite how challenging this looks with July 22 looming, it really does look like that opportunity and that hope opportunity, Tonja. I know how many times you said hope, and it really is inspiring to think about it like that. So let's go to the next slide. So this is a pretty sophisticated audience. You don't need the why. You've heard about why. I do want to make sure everybody's familiar with the rubric, right? This whole, the three lenses, right? Someone to talk to, someone to respond, and somewhere to go. That's become sort of a common mantra. I think it's an easy way for thinking about it. And it's a good way to communicate to people who are less familiar about crisis systems. So we've really embraced this in Georgia and found it to be a good communication tool. Okay, next slide. All right, so in the time I have today, what I really want to do is talk about three lenses of how we're looking at our crisis system and planning for 988. I want to talk about our partners. I want to talk about the projections that are underway, and I want to talk about political will. But the really important point I want to make here on this slide is, in the state of Georgia, just like everywhere, we're not talking about that in the abstract, right? We're talking about how everything that's happening in the national conversation actually enters a current crisis system that is already pretty well developed and has ways of doing business. And now this is the biggest jolt to the system we've ever had. How do we take advantage? So I'm going to spend a minute. I have a couple of slides. Next slide, Jessica. And you'll see I've got Georgia's robust crisis service delivery system. And what I think I'll do in the interest of time, you'll have these as your takeaway prize. You'll have lots of slides that give you a lot of detail on what really is considered to be, and we're so proud of, because we've spent the better part of the last decade building an awful lot of crisis services that are available throughout the state. So you'll see a lot of what these are, and you'll have a little backup information, but I'm just going to highlight a few things on each of these slides because I really want to get to what's next. But as I said, what's important is as we think about 988, it is an interface with a system that is already robust and already in existence. So you see this colorful wheel and the way into all the different kinds of services that we have. The thing right now I want to direct your attention to is what's at the center, GCAL, the Georgia Crisis and Access Line, which is our call, text, and chat center. Next slide, please. So let me tell you about this. And now think about it in terms of the someone to talk to element of 988 planning. This is Georgia's statewide 24/7 confidential free connection to a trained professional. This is our number in Georgia. We receive the calls from the National Suicide Prevention Hotline. We also receive the SAMHSA treatment locator calls. And this is the portal for sending mobile crisis out when it's needed. Next slide. Okay, so you'll see lots of functionality about this GCAL hub, all in the land of somebody needs someone to talk to. Getting someone to answer, whether it's a call, text, or chat, really is the most critical thing. What I do want you to notice here is this is for adults and kids. I also want to acknowledge that in Georgia, you can call whether it's behavioral health, mental health, substance use disorder, or people with intellectual and developmental disabilities, autism, and other related disorders experiencing a behavioral crisis. I think it was Doug who said, or whoever said, we don't want to make it hard. That individual and family are not supposed to figure out what's wrong. They're supposed to know there's a number to call. Next slide. And then some other really cool features that we've built over the course of time. So again, the key thing is you can reach someone, call, text, or chat, and mobile dispatch would go from there. But what's happening behind the scene is a pretty sophisticated management of all of our beds in the state. We do have a live registry of what's happening with every crisis bed that the state funds. Letting anyone who has access to that registry see what beds are available, what they're not. And let me go ahead and preview for you. Most of the beds are full all of the time. So, and then similar to what Doug showed at the end, we've got lots of performance data. We use dashboards. And it's been really important to tell the story because the personal stories are important, but it's really important to be able to show impact. Next slide. Okay, and this is just another peek at what's happening with this hub of calls, this someone to talk to. You have a little bit of a window here. I think the only thing I'll add, when I'm asked in a lot of conversations, essentially our Georgia Crisis and Access Line is, I get the daily count every morning, is taking 600 to 800 calls a day. Every day. And then we have peak times and call spikes and all of that. I'll share one other data point that's not on this slide is that about 37% of people are calling for themselves. About 40% are calling for a friend or family. And about 23% are actually professionals who are calling. They're dealing with someone and it's escalated to a level where they need help. So I think that's interesting data. Next slide. Okay, so now on to, so that was someone to talk to. Now it's someone to respond. And essentially, if the person is in need of a face-to-face response, we do have mobile crisis that's available 24/7, available in all 159 counties in Georgia. And once again, these folks are trained to address whether it's a mental health, substance use concern, or individuals with intellectual and developmental disabilities and autism spectrum disorder. And I'm emphasizing this one. In Georgia, this really has become an emerging and increasing part of our calls that we're receiving. Also note, mobile crisis goes where the people are, and you see that wide array of places that mobile crisis will meet the individual who is in crisis. Next slide. Okay, so here's the same version of our of the wheel that you saw before, and basically what I left in color here, because now we're going to talk about somewhere to go. So all of the colored items on the wheel are somewhere to go. And the two that I've now put in black and white are the pure warm lines, a really critical part of our system, as well as mobile crisis. They're going out, but if someone needs to go somewhere, these are all of the options that we have available in Georgia. Now, like Doug, full disclosure, it's not perfect. It doesn't have exactly equal access everywhere, but we do have some element of all of these all around the state. Next slide. And then here's just a quick snapshot of the actual capacity that we currently have in both adult crisis and child and youth. You see the number of beds, which are either beds that are essentially within a facility, a crisis receiving facility and a crisis stabilization facility, or we can purchase state hospital beds. We have a limited amount of funds to do that. So what you'll see, and you see our numbers there of the total number of individuals being served in this somewhere to go. These numbers are large. This is an accurate reflection of what's happening in Georgia. Next slide. So I've summarized here what the current volume is. And again, using our someone to talk to, and this is FY21 data, 275,000 calls, texts, and chat. And then you'll see, so it's interesting, while every state is different, what you'll see is some similarity in the percentage of those incoming calls, texts, or chats that actually require a mobile crisis dispatch. So it's about 10% in Georgia as well. So you see that there, that's the someone to respond, and then somewhere to go. If it's determined that going to a place is what's needed, you'll see we had a total in FY21 of 32,700 admissions to CSUs, BHCCs, detox, or using our state contracted beds. Now, like Doug said, some of those could be a temporary observation. That could be a 23-hour stay in a chair. It could be with a peer connection in that temporary observation space, but there's a lot of people seeking help and a lot of people receiving help in Georgia. Next slide. Okay, so I said I wanted to talk about our partners. So layering on top of the system that exists, let's talk about our partners. Next slide. So like Doug said, we're super grateful for the 988 planning grant from Vibrant that really, here's what I think it did. It allowed us to invite some new partners to the table. And in many ways, it allowed us to start having a different conversation with some partners we already had. You see, we broke up into 5 work groups. That work is ongoing right now. And some of that is really short term. And then some of that we know points to a long future of how are we really building the future of crisis services in Georgia. There's so many critical players you can see here in this coalition. And again, I'll repeat what Doug said, our partnership with 911 has really intensified in a really positive way because they see the opportunity that exists for both of us if 988 is working well in our state. Next slide. And then, of course, just, I have to say what you all already know. So within our own state, we've got tons of partners in complex relationships, and then you insert that into the national landscape where we've got federal partners, we've got crisis vendors that are our partners, and advocacy and provider organizations all around the country. So my point here is just to really remind everybody it's a complex landscape. And so the more we can keep the focus about the people we're trying to serve. And I think that's why Tonja's story was so powerful, right? Anyone who's doing this work is doing it because they care. But boy, these boxes can get complicated. So that's the national landscape. Next slide. So I said, in addition to partners, I wanted to talk about the projections because they're important. So let's show that slide. Okay, so I don't want to expect that you remembered the previous report of Georgia data, and I'll make it really simple for you. That Vibrant offered every state a projection of their volume. We were so appreciative. We did our own analysis of that as well, adding in some Georgia factors, and our numbers came up really similar. Here's what I want you to say. I gasp every time I say it, but it's important to note what the projections look like now for us. So already in a system that receives a lot of calls, the projection is in year one, the volume will double. So that's the volume of calls coming in. And therefore, what your state planners anticipate is, wow, then we've got to anticipate we probably need double the capacity to respond. So double the mobile crisis capacity and double, even in a state where we have crisis units and other resources available everywhere, there's sort of this intimidating anticipation that, and it's because we want to be ready, right? It's because as that volume ramps up, we want to do everything we can to answer every call and to have the capacity to respond. So we take a deep breath every time we look at this slide, but it's important to look at it and begin planning accordingly. Next slide. Okay, so it's been mentioned about both legislation and the activation of a fee within our state. And what I can say is right now we're in conversation with our governor's office and some of our legislative leaders about what that's going to look like. Our legislative session starts in January, so we anticipate we will be moving forward. And again, we'll be thinking about enhancements in each area. First, someone to talk to. We need some enhancements there, and you can see how we're describing what some of the enhancements there are. Again, with that anticipated projection, we'll need some enhancements to someone to respond. So mobile crisis, how are we going to meet that increased demand? And then finally, and in many ways, most importantly, as needed for people who really are in a serious crisis and need a place to go, how can we advance our system? And in some cases, that's building new facilities. In other cases, it's getting current facilities a little more adapted to the ability, as Doug mentioned, for law enforcement just to drop off. We have some crisis units that can allow that right now. We have some that were not what we call purpose built. They were built 15 years ago, not having that anticipation. So in some cases, rather than building a whole new unit, what we really need to do is expand the capacity of a unit that currently exists. So we're thinking about lots of ways. We're also thinking deeply about how to advance recovery supports, right? It's not just about the place, it's about how do we really enhance that person-to-person connection that really is a part of recovery. Next slide. Okay, so here's political will, and I say this, I use this term with some trepidation, knowing this, we're about to find out in Georgia what's the political will to address some of the things that we anticipate that we need. So first slide. So let me show you what we're spending right now. You see that number in the center, $235 million annually on our crisis services. But let me show you how that's broken out, because that's actually a mix of funding, which is a good thing, right? You want to have braided and you want to have a variety of sources of funding. So what you can see, our GCAL call center, the Georgia Crisis and Access Line, that at 14 million, and the mobile crisis teams at 28 million. Those are both currently financed through state and federal funding. But that bulk of what we have, that 193 million of our behavioral health crisis centers and our crisis stabilization units and the hospital beds that we purchase, those are all funded by the state currently. So Georgia is spending a great deal of money on its current crisis system. And now, next slide. Let me tell you the truth, because I do want to make sure I'm telling the truth. With our robust continuum, I want to make sure you hear from us what we think some of the greatest challenges are. And any of you, all of you on this line, you know what I'm going to say, which is this slide was in place pre-pandemic. And all of these things were true in advance of the pandemic. Every single one of these has been exacerbated by the pandemic in some way. So it's a challenge, workforce challenges most especially, but all of the things, even in a robust crisis continuum, I do want you to know we're aware of the gaps. Just like Doug said, we're planning at every stage. There'll be times where people need to call me and tell me where there's a gap. I need to know it. At the same time, we are looking 2, 3, 5 years ahead for the ways that we want to continue to build our crisis system. Next slide. So I've made it a promise anywhere I go right now that I have to say a little bit more just about the workforce challenges, because it's our number one challenge. We're in the people business and we're lacking people. That's the number one challenge they have. And it's at every level of our service delivery system. I put a few numbers in here just because I found it's been helpful to make it real in Georgia. So not just when I say, oh no, we're short workforce. And let me tell you the other thing that you see in the first box there, we've also had a pretty significant increase in demand as a result of the pandemic. So you see June 20 to June 21, a 31% increase in calls into our crisis system. The other number that I point people to is 60 hours. And that was average wait time for jail referrals, which was 3 times greater than the year before. Y'all, that's painful for me to say out loud, but it's important to, because it tells you about the fight that we're engaged in here, the passionate advocacy that we're doing to both get the call part right, but really to say what we need most is, and I think every single person, every one of the panelists has talked about this. It's the capacity to respond that we're really talking about. And that's what we're in partnership about. So I know we're short on time and I want to allow questions. So my final word, I just go to the next slide. So I don't have a bad news slide on there. Yeah, I want the good news slide, because as challenged as we feel, I hope that you hear my optimism, because I do think that it's the greatest opportunity that our service delivery system has had, the biggest opportunity in decades. And I'm excited about that. And here's the final thing I want to say, and here's why I'm excited, is because we are so much better positioned than we were a decade ago to handle this, right? And we know so much more about what happens to people in crisis. We are so much more ready to incorporate peers into the service delivery system. That's a big part of what we have in Georgia. That's a part of the crisis solution here. And the challenging work ahead, I guess I'll say one other part. I think it's really, as we think about behavioral health of the future, one of the most important skills that we're working on and we believe needs to be developed in the system is that discernment of how do you get the person to the right level of care at the right time, right? That really ends up being a key skill in all of that. So teaching that, training that, coaching that, learning from evidence about what works, really in the end, as we all say, right place, right time, anytime we really want this to work, we're going to be dependent on people being able to connect with other people at a really difficult moment. So I'm excited to talk to my fellow panelists here and also see if y'all have any questions.
Judy, thank you so very much. What a robust system. And thank you so much for your transparency about what you face and how powerful your system is. And and the wisdom that you share around what to really look at in the specifics. I think one of the things when we talk about 988 that is so challenging is, how do we do the nuts and bolts? And Doug and Judy, just really thank you for getting to those nuts and bolts. And Tonja, thank you for, as Doug said, why we do what we do and keeping people in mind. And so, thank you. And Laura for your overview and wisdom on legislation. Just amazing panel. I just wanted to read a couple things, like sort of grabbing comments from the panelists. Hope, opportunity. This is our time. Partners, opportunities, discernment, why we do what we do. Need policy, lived experience, payers, similar standards. We don't know we're in trouble until we're in trouble. The role of peers, 911, 988 coordination, data elements, impact, easy drop off, right services at the right time. There's so much more, of course. And I just wanted to find out before we go to questions from the audience, if what you all think, if you have any questions for each other, any comments about each other's presentations.
Yeah, I've got a question for Tonja, and I wonder if you could share a little bit, Tonja. I mean, one of the things we're really proud of in Georgia is our peer workforce, which really is throughout in so many different levels of our service delivery system. But this crisis work ahead is really challenging. I wonder if you have advice for us on how to make the crisis work palatable for peers, how to both attract peers to do this work, we absolutely need them, but also really how to make sure we're retaining them and sustaining them when they say yes to being a part of our crisis delivery system.
So yeah, that's a good question. I think, the way we look at peers now is totally different, and seeing peers as a profession and also seeing them being part of the treatment plan, whatever that look like, is key. To know that, we can share our lived experience, but then also make sure that we are well equipped to know the whole crisis continuum, to just work closely with, treatment providers, and then knowing what the resources are, but then also, making sure that we have the knowledge to be that voice to, when we're talking about getting people to buy in from a national level or local level, just making sure, peers have that support and have that space where we can grow to be that voice and to be a part of, kind of like at the forefront of pushing the message of 988 and crisis continuum. And I think that when other organizations across the country, like here where I live, Capital Area Human Services, one of the biggest, LGs in the state, they were real intentional about making sure when they did, their annual report, or when they, did their forecast for the future, that they were making sure peers were at the forefront, that they wanted to recruit more peers. And not only that, but have peers at the table listening, to them and seeing what they think would be an asset to, engaging people and keeping them into, treatment and on the road to recovery. So I think that if we can talk, different states and different organizations can talk to other ones about the importance of peers and being a profession, not just being just something, just let's just have them because they're a glorified sponsor, but no, actually seeing, us as a profession and being a part of the treatment team. I think that's going to be what can help us do our job best and be that warm handoff and just be that resource and that conduit for people when it comes to, their own, recovery and, mental wellness. And I want to make sure that we make sure that peers trained and certified. We have to make sure they're trained and certified. We have to. And RI has a good curriculum. I'm just putting it out there.
Thank you, Tonja. I'm going to go to a few questions from the participants. The first question is for Laura. Laura, thank you for the presentation. What seems to be most helpful in getting legislation passed for 988 fees?
Thanks. That's a really good question. And I think what's been really helpful in a lot of states is leveraging kind of the wide base of support for why the fees, why that investment is necessary. And so, I think it is having kind of that diverse group of stakeholders, making sure that you have law enforcement, 911 at the table, making sure that you have people with lived experience who can give you the human side to the story, as well as hospital associations. We saw in Indiana that was really helpful so that they could give to the legislators who were interested in strictly numbers of, well, here is what it means, for the business community, for the hospital association, when we are not having unpaid visits, when we are diverting people from going to the hospital in the first place. So I think it's just leveraging and building out that coalition. So kind of our usual suspects, right, in the mental health community, but then also building that bridge to law enforcement, building the bridge with businesses, making sure that we're having lived experience at the table as well, so they could speak to kind of the human touch. And I think all of that shows of the why. It's not just, well, we want money because we want money, but this is why we need the money. This is the impact this investment will have. And I think that's been really useful for folks.
Great. Thank you, Laura. And Doug and Judy, do you have any thoughts on that as well?
I can tell you what we're up to right now, because as I mentioned, our legislative session will start in January. And we're preparing for legislation that could potentially include a fee. Laura said something that we're finding makes a difference, which is to paint that picture of the future if this is working, right? And our two biggest customers on this are the hospitals and law enforcement. And there's a lot of interest in Georgia about law enforcement. And in many ways, they're our biggest supporters. If you ask the Sheriff's Association, they'll say, give us money. And then second, give mental health money. So we found that when we're hand in hand with them of painting that picture of the future, when this is working in a more coordinated and efficient way, and people don't have to stop somewhere else first, they can get right into the crisis unit if that's what's needed. That's really what our partners have been really helpful with. And it's also been so important for us to have the level of data that we have. I mean, we're fortunate to have a decade of data of what's been happening through our Georgia Crisis and Access line. So leveraging that, I think, and of course, the projections of what's coming have been really helpful as well, making it tangible and real.
Mm-hmm.
The only thing I'd add to what Laura and Judy said is we're also working with our courts and implementing the sequential intercept model and really looking at that intercept 0 and 1. And I think that helps engage some of the people. And like Tonja said, lots of people don't come in with just one problem. They come in with multiple problems. And sometimes you've got prosecutors who are saying, well, they had alcohol or drugs in their system and they have, they need to go to jail because of that. And so having the courts and corrections all on board saying, yeah, let's get people help. And I think makes a big difference. And so that's one additional partner that I think is helping us in a new way with this at the front end.
Thank you. Thank you very much. This question is for Tonja. Tonja, thank you for sharing and for your inspiring message. How do we do a better job of reaching marginalized communities? Now, I have an addition to that question because I had it when you were speaking about, you mentioned that African Americans really don't call crisis lines and, who's on the other side of the call. And so I was similar to this question. I was wondering, how do you build that trust? How do you culturally message so that it's a message that these crisis lines in the system are safe to go to?
I think it's just, first and foremost, just education, again, because historically we don't, we're told you don't go to therapy. If you do, you just, take it to God and, and leave it there. And so we have to just do a better job educating people that, this is the first line of defense, that it's okay. A lot of times when, we have to make it okay when we're calling a doctor's office. We don't know who that doctor particularly is, but, we have to trust somewhere. And so educating people about what, crisis is, what trauma is, because we still think people know and they don't. But also making sure that we are being intentional to get to those, underserved or those communities of color, and educating them about why, what 988 is, why it's okay to call someone, how that whole system works. Because if a person don't know, that's where a lot of their fear come in. But to just walk them through, what that looks like. And I'm talking about families, because like, Doug said, it's mostly families when crises are happening who makes that initial call. So we have to start with education from even an early age, just like, we talk about the crisis line, which is, amazing. We do the same thing, but bump it up 2.0. And I think it's, getting the message out there, making sure the message is intentional for communities of color to know that, when you call 988, it's not going to be like calling 911, because that's the biggest fear. This is going to be different. And this is what that different look like. And so once we message that, I think that's the first way we do it, and be intentional about before July 2022 happens. Because if we wait, then we missed it. And a lot of people are going to still call 911. And my biggest fear is that those who know, or those who are in a different demographic, going to call that number. They're going to get the help. We're going to continue to call 911, and we're going to still interface with law enforcement. So I think that's where we have to, do a good job at getting that message out.
Wow,
Megan, if I could just add, because I think everything everything that's been said here today has just been magnificent. And I just also want to build on the fact that, there's the messaging component, because we want communities of color to know that this is an option. But then there's the work behind that Doug and Judy referenced of, if your initial experience is not a good experience, or if the only option, if you need an in-person intervention, is still law enforcement, then that's just, it's another door to get you back to law enforcement. And then that's not going to help build trust within the community. So we do have to message, but we also have to make sure we're also doing the work behind the message to coordinate the continuum in a way that serves those marginalized communities best.
Mm-hmm. Great. Thank you. Do any of the other panelists have anything to say on this?
Megan, I'd like to just follow up on a couple of questions, if that's okay, and they're related more to what we've just been discussing in terms of implementation. I think one of the things that I think, everybody's talked about is the crisis spectrum in a way. And the reason I think we've been emphasizing crisis services for the last decade and in all its different forms is because of the inadequacies of the larger system. The larger behavioral health system is not able to sort of deliver the right treatment at the right time at the right place. And therefore, we are putting more and more emphasis on the crisis development of that whole spectrum. And now we're expanding the crisis system, and it's going to put, as Laura, Judy, Doug have all, and Tonja pointed out, is just going to put more pressure on the larger system, which is almost, in a sense, set up to fail because it is not adequately funded. So that's one kind of issue that I'd like the panelists to discuss. But the second is, having been involved with a lot of change and transformation systems in behavioral health, it's within a state and across states, it's not going to happen uniformly. There may be this wish that we go from 911 to 988, but that's not going to happen. There will be some people who will, in a state, they'll do it well in some localities, and others that will not. And so I'm just trying to understand, as you're dealing with these implementation issues, how those implementation issues are being addressed from your perspectives?
Who would like to
So,
go? Judy.
I'm happy to take a start at. Thanks for the impossible question, BJ. But that's what we're here for, right?
Yeah,
Is to
that's
be
where the
truthful.
rubber hits the road, right?
Exactly. So importantly, I couldn't agree more about your assessment of this buildup of the crisis system, and seeing what the impact is. And as we say frequently here, if you build it, they will come. And what we do see is a lot of people entering our system through the last place we want them to enter, right? Which is through the crisis portal. So it's good that we've made it easier for people in crisis to have a place to go. At the same time, it's heartbreaking, right? That we don't have the same amount of emphasis and energy around how can we just make it easy at the first sign of trouble. One thing I can say is this: we are in pursuit of additional funds. We do feel like we've got to enhance our crisis system. At the same time, we are also seeking funds to increase outpatient services all across the state, because we agree. And I really want to go back to this last point I tried to make at the end there, that ultimately the discernment is, can we get this person to the right level of care? A lot of people who call our Georgia Crisis and Access Line aren't yet, and I think either Doug or Laura mentioned, they're not yet in a suicidal crisis. And can they experience a system, doors, clinic doors, which are now sometimes technology portals, right, that feel accessible, and they feel like I'm going to a place where I'm going to get the kind of help that they need. So there are a lot of elements of access around that, but I really appreciate your bringing the point forward. Every time we talk about crisis, we have to be talking about, and how could we prevent this in the first place? So we're all in on thinking about the same thing, both at the level of the individual, right, and then at a system level. It's such an important point.
And I'd like to add on to that is that, again, having conversations like this and having them on a continual, like every Wednesday at 12 o'clock, there's a crisis jam. And a lot of the folks that are on this panel, are on those calls. And it's been a game changer for me and other people that I know, because what's working well in one state, that person don't mind disseminating and sharing that information. And that's how this is going to work. We have to disseminate that information and share it, what's working for us, what's not. And I think that, again, having these dialogues on a consistent as states are building their crisis continuum is a good thing, because we know there's evidence-based programs out there. So if Utah is doing something or Georgia's doing something that we don't know in Louisiana, let's connect and let's talk about it, and then put our own flavor on it, just like we do in Louisiana when it comes to food. We'll take a recipe and then we'll put spice on it and it works for Louisiana. And I think it has to be the same way, because you have vibrant, people who've been doing this already, no sense in trying to reinvent the wheel. How do we make it better? And I'll go back to buy-in. I was talking to some police officers the other day in a training, and I asked them, how many of you guys know about 988? And out of the 300, only 2, So again, as we move forward, we just have to make sure that we're getting that buy-in, from everybody and getting that message out. And I think that's going to help us. But yeah, sharing that information on a continuum is going to be, I believe, key to helping states, all of us do it right.
And I just want to echo what Judy and Tonja said and say, we've seen, like Georgia, as we've marketed this more as a crisis line instead of a national suicide prevention line, just our rate of increase in calls is much higher than the increase for those that are still just marketing as national suicide prevention. And that's dropping our call rate because we're trying to keep up, and that's not what we want, because then when the call goes out of state, then you don't access our continuum of care that we're building. So it defeats the purpose, right? And so we're really, trying to grapple with that. One of the things we're also doing that I just put in the chat to everyone is a statewide suicide prevention and kind of stigma reduction and resiliency. This is what suicide prevention looks like campaign, right? And so we have some funds that's in a governor's special fund that has private donations, and then the legislatures put money in that's targeted this campaign to try to get further upstream and help people before they need our services. And, you know, I think that that has to be part of the solution. And, you know, the more we can get faith-based communities and, you know, other stakeholders and partners knowing about these resources, and then doing suicide prevention and crisis prevention and resiliency work in the schools and in the churches and in the places of worship and in the community, I think that's where we're going to start to move the needle on that front end.
Thank you. Thank you.
I have a question around 911 and 988. What advice do you have to have that interoperability? How do you do the buy-in? How do you do the partnership? How do you make sure they don't compete with each other? How do you do the handoffs? And yes, you could have police that are CIT trained, which I think is important, but we're also trying to divert people from jails, from emergency rooms. And so how do we really work that? And it's one of those, okay, you got to have a conversation. Well, what is the conversation? What is being said?
Well, I'll just kind of lead off from Vibrant's perspective. And, you know, certainly we see law enforcement 911 as partners. So it's not an antagonistic relationship, because I think, you know, from their perspective, they don't want to be spending their time doing this work. And I think there's a recognition that this work can be better served by allowing those with mental health training to provide the intervention there. Vibrant and SAMHSA are working closely with the law enforcement groups and the office. I know SAMHSA is working closely with the Office of Emergency Management under the Department of Transportation. But I think when it comes to kind of the rubber hitting the road and the local level, it is building those relationships and helping them understand that, you know, 988 and the Lifeline crisis centers and mobile crisis teams are really there to take that burden off of their plate, that we are collaborators in ensuring that we're keeping individuals in the community safe. You know, I'm sure, you know, don't want to deal with I read something where it's like 20% of law enforcement time is spent on transportation runs. So I think all of this really, you know, I think we have to educate our law enforcement partners on the Lifeline, the resources, mobile crisis teams. So I think it'll be kind of, from our perspective, you know, a journey. But I think when we're seeing the legislative initiatives, they're already at the table. They want to be a part of this conversation. So I think it is something that they're very interested in. Of course, it won't be fixed overnight, but you know, I think it's something that we should approach collaboratively.
Yeah, and I want to say that, so about a couple of months ago, I was a guest speaker for the National CIT Conference, which was phenomenal. They did a great job. And so for 3 days, I spent a lot of time talking to law enforcement, you know, EMS, you know, police officers here. They are excited. You know, they know they're not social workers. They know that they need help. And a lot of times they feel helpless and feel like the only thing that they can do to keep this person safe from themselves or someone else is to do that. So they like knowing that there's an option. They like knowing that they have a crisis stabilization center or someplace else. So they're excited about this. Like I said, you know, when I was talking to some, you know, not too long ago, they cheered when they heard about 988. And family members are going to be excited, because when I always tell them you have to call 911, they go, is there any other way? Is there any other number I can call? Most of them always ask that question because they're afraid of what could be, you know, not putting dibs on law enforcement, because again, they're not social workers. And you're thinking that it's going to look like it is on TV and it's going to happen that way. So I think once people know that this is different and that this is that, and to let them know how that whole system will work and how it'll play off from the first initial call to whatever that, treatment plan look like. People are excited just from even the stuff that we're doing on the street, and the messaging that we're doing. People are excited. You talked about faith-based organizations. That's also my community as a pastor. And so getting that information out, they want options, and people don't mind, making that call when they know that their loved one is going to be treated with dignity, respect, get the help that they need, and not maybe, already have a traumatic experience become more challenging.
One of the things I would add to that is, I think for us, sometimes when people think about CIT, they think it means crisis intervention training, not crisis intervention team. And it's a team. It's advocacy, it's mental health, and it's police. And what we found is the most successful is if we get calls and people are saying, hey, what about CIT? I say, well, why don't you talk to this sheriff or this police chief or whoever and let them tell you about it, because they speak your language.
Yeah.
And doctors, just like doctors want to hear from doctors, police chiefs want to hear from police chiefs about how it, CIT or 988 or MCOT teams are working. And so I think finding those people that are your advocates basically, but they're just happen to be, police chiefs or, whatever else, that's where it's been the most successful for us to grow CIT. And making sure that the team is there to support it, that it isn't just the officer gets trained and then they don't have the backup of the mental health and the backup of the advocates for the support system and for the treatment system. And so I would say that's been really helpful. We're actually, we've done some training of dispatch as well on CIT. So we have dispatch training that's different than the full law enforcement training that we do, that I think's been helpful, that some dispatch and PSAPs have been interested in. And one of the things that really got 911 to the table in Utah was fear. And I'm just, we're being really honest here, right? They were afraid that when the legislature heard that 10% of their calls were going to come to us, that the legislature was going to cut them 10% of their budget. And so they said, hey, whoa, wait, you can't say this. You can't say this is what's going to happen. And we said, well, we're hoping this happens. And they said, but we're still going to have calls. And I said, yeah, and some of these calls, we're going to need to coordinate with you too. Like, we're still going to need you strong and there to support us as well. So they've been named for the next 2 years as temporary members of our Crisis Response Commission to deal with 988, to make sure that we're not, negatively impacting 911 operations and budgets and all of those things. And then we're talking about interoperability of the phones and dispatch and different things like that as well. And I think those discussions have been really helpful for us.
Yeah, if I could just underscore a couple of things that have been said. First of all, BJ, you said it right, which is it's going to look different in every state. I mean, ultimately, you'll get to the standardization that we're looking for. But right now, it's so complex in each of our own states. So I'll give you a little snapshot from Georgia. 911, who's been a great early partner in this, right? Because it still feels like we're early in this. In Georgia, we have 159 counties. Each county has its own 911. Wow. So, right, leadership matters, I think, is one of the first things that I want to say. And having the early conversation be about what's in this for both of us has been really, really important. We're really fortunate to have great 911 leadership in our state. And then the second thing was, as Doug already alluded to, and because he's a clinical social worker, he already knows we got to meet people where they are. And where 911 in our state is that they had their own giant strategic plan of next generation 911. And a lot of your 911s might be doing the same thing. So they've got this whole big plan of their own that was not anticipating Judy and the behavioral health folks walking over and say, wow, have we got a plan for you? So it's been a really I feel really grateful that they did see the opportunity that we're talking about. But we're in the easy part right now. But the easy part takes a lot of personal work, right? And again, it just underscores we got to be able to do this stuff virtually now, because sometimes it's the only way you can get together. So good thing we've learned a lot of that already, because we have hard conversations. In the end, those interoperability, that's going to be complicated. In my own experience of system change, when you start those complicated undertakings with personal relationships and trust, because we believe we're headed to a shared future where people in Georgia, in our state that we all care about, get the help they need quicker. Really, you just keep rallying back to that. But I think the personal relationships right now are so important, because wow, did we bring a big surprise to the whole 911 effort in Georgia. But this is a part I'm really optimistic about. And I just got to give credit to team members who are really working through those relationships.
Can I just add that, like in the diffusion of innovations, you're not, I mean, you're going to have early adopters, and you're going to have people who are going to be slower at getting to those things. And in every field of literature, the incorporation of the early adopters in the future diffusion process is always a stepping stone to success. So it's whoever is doing it well within a state, among counties, is to really make them part of your messaging team, your dissemination team. So I just think that that whole general model of the adoption of innovations applies very well to this context.
Fantastic. BJ, we still have 3 minutes. Do I have time for another question, or should we pass it to you?
I think if there's one more question, go ahead and have them ask it.
Okay, great. One of them was about to the whole panel. How do we get the 988 message out to the private sector and private insurance? Who's first? It's a tough one, right? Yeah, but it doesn't happen.
Well, I'll take a quick stab and repeat what I already said, right? Which is meet people where they are. What do payers need? And there's partnership in that, in asking the questions of what is it that you need for your members? And I think that's always the starting point, because we're going to hear a lot of things, but part of what they need, we're building some answers to, and it's going to be much better if they have influence in the early stages. So that's my starting point. Love to hear from others.
Well, Judy, I was going to say the same thing. I think that is such a great starting point, because it allows folks to understand that we are aligned, for private insurance, and what this means that, you don't have to pay out a costlier bill because they went to they had to move up the service level. Certainly I think I don't think we want to get too much out around 988 messaging before we have the capacity we need, right? So I think we're going to look to our federal partners on what that looks like. SAMHSA, HHS, what does promotion of 988 more broadly look like as we're building capacity for the context now, and that projected 6 to 12 million. We really need to have that in place before we tell everyone to go call, chat, or text. So, I definitely agree, Judy, that we need to meet people where they are, let them know why they also have a stake in this too.
The other thing I would add to that awesome answer from Judy and Laura is, as more health systems move towards value-based care and move towards capitated plans where they're looking at determinants of health and how they can impact the part of health that they haven't impacted as much because they've been focused on the 20% that healthcare drives. I think that's where we have some real opportunities, because we've been doing determinative health work and behavioral health for 30, 40 years, 50, I don't even, go Dorothea Dix, right? Like, I don't know, but that's always been part. So I think there's a lot of room there where they're going to see the value once we can show it. And to Judy's point of being able to show your data and the impact, that's what I think is going to turn their heads and have them get on board.
Fantastic. I just have to say, we do need to wrap up. I have to hand this over to VJ. I don't want to hand it over to VJ. I want to talk more with all of you. I've had the time of my life today with you guys. And I just thank you very, very much for sharing. It's been incredibly insightful. I hope you see in the chat all the positive comments and how helpful this session has been. Thank you all for sharing your wisdom and insights.
I just want to quickly echo
Thank you, Megan.
what Megan just said, and thank you, Megan. You did a fantastic job moderating and keeping everybody on track and keeping everybody on point. I have a couple of quick housekeeping things. One, the code for the CEU evaluation is NOLA, N-O-L-A -22. And that's what you need to include when you send in the evaluation to Melanie Norwood at the email address that I had on earlier. Second, we're going to end the session, but what should appear on your screen is the link to the evaluation. Thank you all for being so responsive to the evaluation of session 1. We would also like to see that same kind of response for session 2. Thank you all again for attending. And again, if you have any suggestions or comments, we're trying to incorporate your feedback into every session in a quality improvement kind of fashion. So thank you all again. Thank you.